Well, kia ora, everyone. Thank you so much for joining us today. I'm really looking forward to hearing from Liz. We are going to begin, though, with our opening karakia, um, uh, wonderfully provided by Sue Reed. I'll hand it over to you, Sue.
Kia ora, Ragnar, thank you. This is a karakia that was written for us by former staff member Jen Gilby, who will be known to many of you, and translated by the Māori Language Commission. So, mō te karakia, kia puta ngā mataranga o te hunga o teina e tōnei, me ratu ko mene atu ki te pō. He arahi I a tātou I roto I ngā akaranga, me na whakataanga I whaukika ai, a tātou kirataki me a tātou hō mahi, ka whakamoemiti ki na hiranga te taia e te toko nei I a tātou.
Lovely. Thank you, Sue. Well, it is my pleasure to introduce Liz Pennington today. Before I read her bio, I do just want to do a little bit of housekeeping. Please keep an eye out for future emails about presenters. We've got a really exciting lineup almost for the rest of the year, but there are a couple of open slots. So if there's somebody that you think would be interested and open to presenting, or if you yourself would like to present in this forum, please don't hesitate to reach out to me. I'm pretty easy to find online. And yeah, it's just really wonderful to have you all here today. So, Liz Pennington, she is the Chief Executive and Lived Experience Lead for the Ovarian Cancer Foundation of New Zealand. She's a registered nurse and has worked in women's health, trauma response, and mental health, education, and the non-for-profit sector over many years. She is the national chair of Breast Cancer Support Aotearoa and volunteers her time facilitating online support groups for women and training mentors. She also serves on the National Mortality Review Committee and on the New Zealand Mental Health Review Tribunal. She has a strong commitment to lived experience and women's voices informing care. She lives in Tauranga and is a proud mom and grandmother to 4 children. So with that, Sue, excuse me, with that, Liz, I'll hand it over to you to do your presentation. And we'll have some Q&A opportunities at the end.
Yeah, thanks so much, Ragnar. So, tēnā koutou katoa, ngā mihi nui ki a koutou katoa. Kia ora, everybody. Thank you very much. If you haven't yet got a cup of tea or coffee, please feel free to grab one so you can kind of have a sip while I'm chatting, because it's going to be a bit more of a conversation than anything else. So, thanks so much for the opportunity to talk with you. It's been lovely catching up with Ragnar and sort of looking at this opportunity, and it was great connecting with you, Jackie, again. At the State of Ovarian Cancer launch back in February. Where did those months go? I'm not sure. But it was just lovely to have lots of us who've been working in these spaces together over many years coming together, and then subsequent to that, looking at what we can do on a collaborative basis to support each other. So a little bit about my why. My why was two things really. My very close friend Galen Kepka died of ovarian cancer, and I made some commitments to her around the need for support services for women. Galen had breast cancer first, followed by ovarian cancer, and talked about just the difference in terms of the support that was available. And obviously that was some 15 years ago now, but in Galen we lost 10 years ago. So and my other why was hearing Jane Ludeman speak at Parliament. It was International Women's Day. And as is usually the case, they'll bring in a number of people speaking. So we had Tash from Talk Peach, who spoke beautifully, followed by Jane from what was then the Cure Our Ovarian Cancer and is now the Ovarian Cancer Foundation. And I just felt compelled after hearing both of these young women speak about their experience to do something, and kind of, I suppose, just had that sense of, once you know it, you can't unknow it. Once you've heard it, you can't unhear it. And so then what was I personally going to do in terms of supporting? So that's how I came to be involved. So I have served as a trustee since about, I think that was about 2021. And then I've just been in this role a year this week, actually. So I'm still very much finding my feet and have loads to learn. So I think the important thing, as you would have heard in the title, is, facilitating lived experience voice is a big part of what I do. CE is the other handle, which is still important, but that lived experience piece is hugely important to the Ovarian Cancer Foundation. So having this opportunity to talk with you a bit about some of this work that we've been doing in the general women's health space feels like a really important opportunity as we then also think going forward about what else we can do together, because there's much to be done. And it is actually going to take not just organisations on their own, but alliances, and a real army of allies, really, if you like. So processes like this I see as just helping embed that, helping extend the number of us who are kind of coming together on issues and saying, hey, not good enough, or hey, it's time for positive change here. And we've got not only some solutions, but those with lived experience who have something to say, and you would benefit from hearing their views. So what I'm going to talk about in the session, I'm just going to share my screen, and this is where, even though we've practiced, you hold your breath just a little. So Ragnar, can you just give me a thumbs up so I know we're all good? Right, great. That's fantastic. So we launched this report in February of this year. So I just want to, in the presentation, step you through what we found, what women with lived experience said to us, the work that we did preceding the report's writing, and the role of women with lived experience in this space, and then open up for a bit of a Q&A at the end. Ragnar can keep an eye out if there's things popping in to the message box, so feel free to stop me, Ragnar, if it feels important to do so. Sometimes we can wait to things at the end, sometimes things are pressing, and so I'm really happy for you just to signal to me as we go. So if we begin then with the work. So this is the cover of our report, which was really summarising and looking at what the state of ovarian cancer was in New Zealand, and bringing together evidence informed by 3 surveys that we did last year. A survey of the general public, so we asked them a range of questions, a survey of women with lived experience of ovarian cancer, and a survey of both general practitioners and general health practitioners that we also did, again, asking a range of questions. Now, we already had some thoughts about what was happening, informed by the women that we interface with and their families, but these surveys gave us another kind of important anchor point, to really, I guess, affirm that what we thought was happening was indeed happening, and with some evidence to really back that up. On the cover here we have Ruby Smith, and Ruby was part of our lived experience advisory group, and was the face for our report. That photo was taken in the middle of December last year in Christchurch, where we got together and did some photo and videography, and you'll see some of the videos out on our socials, including Ruby. And Ruby was to join us and speak in Parliament at the launch of our report. She had said to me quite clearly that she wanted her voice to be heard. Unfortunately, Ruby passed on Waitangi Day, just immediately before the report. So we just acknowledge her and her efforts and work that are reflected in this report, and of course her family. So the report began, we did our surveys, and the report began with women's voices. So we wanted to hear what women had to say, what was really evident from the survey, and we went with our survey questions to women with lived experience, and they made some suggestions to us and some changes that we incorporated as a result of that feedback, was that women's experience was not the same. There was quite a considerable amount of variation in terms of people's experiences. So when we wrote the report, we didn't want to write a sort of an executive summary and your stock standard kind of report. Women had said to us, we want something that's readable. If things aren't presented in a way that's readable, our sense is that it's not really created with us as an audience in mind. And so we'd really like to hear what we've got to say about that front and centre. So when we prepared the report, we opened with women's voices at the beginning, closed with them, and then sort of wove them through, if you like. In meeting with women ahead of the launch, they talked about wanting to very much be part of it, Many of them weren't able to travel for health reasons, for financial reasons, for lots of reasons really. And so they asked for the opportunity to participate fully, and for us to live stream. So that is what we did. They also asked for an opportunity to hear about the findings first. So the idea of kind of no conversations about them without them. So we did a pre-launch, and engaged with our community ahead of the launch in Parliament itself. So again, I guess just examples, aren't they, of the importance of asking and listening. So we had here some woman talking about the experience of dismissal. You can see that in that top quote there. The experience of dismissal was something regularly raised as an issue by women, not feeling listened to, not feeling that their concerns were taken seriously. For some women presenting multiple times without any referral for further testing or anything like that. In contrast, we have the comment at the bottom there from another woman saying, hey, my OC, my ovarian cancer was picked up early because from the moment I went and saw my doctor, I was sent straight away for a blood test after 10 days from my first symptom. So there we've got a good experience, and ovarian cancer being picked up early. And then on the right there, I didn't know that the discussion, would be, sorry, I'm just moving that over there, that discussing cancer would be part of my diagnosis based on the symptoms I was presenting with. I would have felt embarrassed to even mention cancer as if I was overreacting. So just acknowledging those voices, the variation amongst women of their experience, some common touch points though around the experience of dismissal. And around a number of women's experience of going repeatedly with similar issues. So many of us will know quite a bit about women's cancers, but that may not extend to knowing very much about ovarian cancer. When we think about, the number of women diagnosed each year, you might look at that and say to me, well, that's not a lot of women, 306. But one of the key factors here, I guess, is when we think about how lethal this particular type of cancer is, and that when we contrast it with other cancers and 5-year survival rates, this particular cancer, where it doesn't have a current screening tool, really the only way we've got the opportunity to cut this off at the pass as early as we possibly can is by women being diagnosed early through an awareness of the signs and symptoms. So we've got 306 women diagnosed every year, 207 dying, 30% dying within 1 year, and a 43% 5-year survival rate. Now, if you compare that with breast cancer survival rates, which dependent on the type of breast cancer you have might be around 89 to 91% or around that figure. If you think about prostate cancer, I think it's mid-90s. Bowel cancer is about 60-odd%, I think 66%. So we're well shy of some of those other more commonly known cancers. And of most concern as women, I think, is the fact that nearly half of us are actually getting diagnosed in an emergency department. Now, I don't know about you, but emergency department wouldn't be my favourite place to be unless I absolutely had to be. And so this tells us something about what's happening for a woman that she finds herself in an emergency department for diagnosis. And so for many women, being in an emergency department might see us not only being told we've got ovarian cancer, but being told that, a bit about likely prognoses and those types of things, which obviously is, a pretty hard message to be receiving. So those rates are high. You might say to me, well, given it's ovarian cancer, probably it's just high anyway. But that's not correct. If we look at other comparable countries like our cousins in Australia, for example, and we look across the Tasman, their rate of emergency department diagnosis is still a reasonable number, but it's sort of anywhere, because they do it by state, anywhere from sort of 21 to 28%. So we're a lot higher than that at nearly 50%, aren't we? And that speaks to the fact, I think, that the clinical pathway in Australia is a little different to the clinical pathway here. So half of our women are finding themselves diagnosed in ED. So that's an issue for us. That 5-year survival rate is moving upwards, so we'll take that gain. That's a good thing. The last time we looked at that, it was 36.6%. So 42.8 or 43% is a lift in that, which is good to see. When we did our survey, most people had heard of ovarian cancer and indicated in our survey, ovarian cancer, yes, I've heard of it. Can you name any symptoms? No. So herein lies a significant issue for us. So we've got in our surveys, and it was 500 New Zealanders, a large number thought that their cervical smear tested for ovarian cancer. So that was concerning to us, and it's something we've heard before. Why is it concerning? Because if you believe that you have a clean bill of health as a result of your cervical smear, even with the changes in the system as it is now, if you think that that means that everything else gynae is covered by that, then we have an issue, because that can delay further help-seeking behaviour for some. It can give that a false reassurance that there is nothing wrong. You just have to perhaps manage the symptoms, the sorts of things that you're dealing with. A number of people also believed that the HPV vaccine meant they could never get ovarian cancer, and that ovarian cancer wasn't an issue for them. And in our conversations with women, a number of older women thought and expressed the view, and again we saw this at field days as well in conversations, that ovarian cancer was not an issue for them because they were past all of that. All of that stuff, meaning periods and menopause and all of those sorts of things. And we know the average age of diagnosis in New Zealand currently is 65. So the fact that we have an older age group of women, like myself, not quite 65, but heading in that direction fast, the fact that we don't think this is relevant for us, that's concerning too. So cervical smear, not understand, we need to know why we're doing it, but we also need to know what it is not testing for. The fact that HPV vaccine doesn't mean you can't get any gynae cancers whatsoever. We certainly want our younger women, especially that younger cohort, to understand that, and our older women to realise that this is still an issue for them. So some stats to start with kind of, I guess, anchor us in terms of, so what do we need to do if this is what the community thinks is the case? So when we're thinking about all of this and why early diagnosis matters, as I said to you, we don't have a screening tool. Now, many people don't realise that, but there is not currently a screening tool. So symptoms can be missed or dismissed. There is no doubt about that. Women will often talk about really long delays in getting diagnosed, 1 to 2 years. Some of them will talk about the quote we've got in there. About 2 years and the need to be taken seriously. And the key then is that earlier recognition can improve survival, because we're going to be able to cut things off at the pass earlier. And if we've got emergency diagnosis, you're always going to be thinking then, aren't you, about disease progression? Because if a woman's actually ended up in ED after presenting already to primary care on multiple occasions, then over what period of time has that happened, and what has happened in terms of her disease during that period of time? That's the concern. So when we did the presentation in Parliament, we spoke to these kind of key points, the things that came up and out of those surveys and the discussions subsequent to. And you can see there the actual stats coming out of the survey. It's on our website, so if you click into it, you can either jump in and have a read. If you click into the QR codes, we kind of layered it up in the first layer, the overview, and then QR codes to dive into the details. If you wanted to see the actual survey questions themselves and things, you can. But we just didn't want to have all of that within the main body of the report. So you've kind of got like the layers of an onion, really, where you can dive deep into the stats if you want it, or look at kind of a more of an overarching kind of overview of it. So you can see here the sorts of things that I've been talking about, what people were thinking about screening. You can see, the number of people that know of ovarian cancer is quite high. I read that and thought, oh, that's pretty good, until you then look at those that know some signs and symptoms, which is much lower. So that's Minister Grigg there. She gave an address as part of our launch, so we're grateful to her for that. And some of the barriers that women talked about, and that others that we surveyed talked about. When we spoke to GPs and said, what do you consider to be the biggest significant factor in delaying of diagnosis, they talked about access to ultrasound being the key issue. Now we know that's variable. We know some's done within hospital settings, some ultrasound services are contracted out. There's a variety of things happening in that space. But access to ultrasound appeared to be a key view of being of concern. Women shared with us in the surveys also that they'd been advised in their first appointment that if they could, they should pay and go privately because the wait time would be reasonably significant. And we know from an equity point of view that will then translate to some people being able to do that privately, but there'll equally be those who are not able to do that. And so, we're looking to have a public system that provides that for all women. So prior to diagnosis, 75% of women's symptoms were attributed to things like irritable bowel syndrome or IBS or menopause generally. 1 in 5 women had to wait over a year from their first visit to diagnosis. So you can imagine too, if you're going in and you're being seen, and of course quite often these are 15-minute slots, aren't they, the appointments and things, and it's likely that you are going to look at those things that most commonly might be an issue first. But when somebody's repeatedly going, then we would expect some, or we would hope to see some further investigations or something happening as a result of that. So this is Erin in the photo here, and she's a really proud ovarian cancer advocate. She has lived experience, and so she shared at the launch her experience of diagnosis, which was similarly delayed, and certainly she talked about a sense of dismissal in terms of her experience. And so when we think about that, so we think about the data, we think about what our lived experience community are telling us. We think about what we know as a foundation in terms of our interface with women in our community. There are some key things that come back to one theme, and that is around the lack of data. Why do we need data? Because data can inform research, it can inform treatments, it enables clinicians, it enables women, it enables researchers to have a sense of what's happening. There is currently no ovarian cancer register. So at the moment, if you think about it then, so what do we collect? In terms of register, we collect, say if we take me as an example, and I've had an experience of cancer, but not ovarian cancer. We might record, say if I was to be diagnosed with ovarian cancer, then we'd record Liz Pennington, diagnosed with, say, high-grade serous ovarian cancer, stage 3. So that would get recorded. Then later on, in terms of mortality data when I died, that would be recorded. But in between, there's no publicly available register recording what's happening for me in terms of treatments, in terms of pathway, in terms of any of those things. Now that's hugely helpful to be able to look at in terms of saying, well, look, this cohort of women are doing much better. What's happening there with this particular pathway? For researchers to look and see opportunities for future research, for things that they could be looking to do. But good research requires access to data. It also needs access to a biobank and tissue samples of New Zealand tissue, New Zealand-based tissue. And we would have then clinicians and women benefiting from those treatment journeys being way more accessible. So I popped the picture in here of Dr. Alicia Didsbury. She's one of our trustees, but she's also a researcher at Auckland University, and someone she spoke at the launch also just about the necessity of data to inform everything that we're talking about. So in terms of the work that we're doing in this space, We've got 4 or pillars, if you like, and each of them are the things that we're involved in. Obviously, the awareness work, and in the absence of a screening tool, we know that awareness is absolutely essential to saving lives and identifying ovarian cancer earlier wherever we possibly can. So we do lots of work in that space. So that's digi screens and or sort of digital screens in primary care practices. It's community notice boards, it's wallet cards, it's posters, it's being at the field days that I was just talking about, or we'll take any opportunity we can to try and promote awareness of the signs and symptoms and an understanding of ovarian cancer. Then it's the advocacy work, so the launch, and all the actions that have followed from that in terms of meetings and follow-up around the 8 asks that sat in the back of that report. Support services, so those are the things that we're doing now that I talked about in regards to my late friend Gayleen not having access to, but I'm pleased to say are now available, and that is online support groups where women with ovarian cancer can speak with other women. Because there's something pretty profound about peer-led services and that kind of peer-to-peer opportunity to talk with somebody else who's been there too. And we've got 30 different subtypes of ovarian cancer, so not everybody's experience will be the same. But there are some important things that are similar to people's experience that are really able to strengthen and assist women in their journey when they're able to talk with and connect with others. So we've got online support groups. We're just starting online support groups for family members because there currently hasn't been anything for them. And we've got one-on-one counselling that we fund, rongoa Māori that we fund, and also rehabilitation sessions that we fund. So those are currently the support services that the foundation offers. So that's an important part of what we do, and then research. So research we know is part of the answer and our kind of vision of women being able to live a quality life, and for us to be able to find a cure for ovarian cancer. So research this year, we're funding 2 $80,000 grants for New Zealand research. We're funding 2 travel grants to support people to travel overseas and work alongside ovarian cancer researchers and bring that back to New Zealand, and 4 professional development grants. And we do all of that work through a partnership with CRT, or the Cancer Research Trust, who review the applications and make recommendations for us to then consider and approve. So in terms of those 4 pillars of work, we don't receive any funding for any of that. We fundraise for all of it, including our research, and that's an important part of who we are and what we're doing, is to recognise that these 4 elements are interconnected and each require the support of the other. So, we wouldn't be giving effect to our mission if we weren't investing in research. We wouldn't be meeting the needs of women now if we weren't focusing on support services, and similarly in the awareness and advocacy space. So that's a bit about who we are and what we do. So what I'm going to do next is just step through the 8 actions that we identified in the report, because I guess we got to a place where we thought, well, it's fine to gather all the data up and summarize what we found, but how useful is that in a report format if it isn't accompanied by the actions that will truly shift the dial and transform outcomes? It's going to be hard to have one without the other. So the back section of the report lists the actions. So these are all areas of work for us currently. Some of it we're leading, some of it we're behind and supporting others who are leading some of these areas, but we have an active stance in each of the 8. So of priority for us is, of course, this first one, which will be of no surprise to you, which is to reduce that gnarly incident rate of diagnosis at ED. We don't think that half of all women being diagnosed in emergency departments is an acceptable statistic in 2026. And the 2 key things we're pushing into on that space is making sure that there is that information around the cervical screening program, not testing for ovarian cancer, and also particularly that health pathway around symptomatic women who present being sent for both ultrasound and blood test. So we're doing what we can in that space. And of course, I've also referenced HPV, which has come up in more recent discussions, as well as in a couple of the surveys. So data gaps and making accurate, more real-time data, because that's what you're going to get with a register, right? Is people being able to input and having access to real-time data. There is an absolute need for a register. There is work being done currently by the Cancer Control Agency on a platform called CanShare. We are hopeful that ovarian cancer might be able to be first cab off the rank, as I might say, but, be and there to be an opportunity for us to potentially be part of that, or the first part of that. So we're in dialogue with them about that. And we've got an idea of what that would cost to fund. We want to identify people at higher genetic risk before they get ovarian cancer. So there we know that 10 to 15% is hereditary. And so the rest is not. So we want to reduce the BRCA testing thresholds. So you may or may not know a bit about BRCA 1 and 2, but basically when we're thinking about that, it's important because those are the genes that help repair damaged DNA. But where there's a BRCA mutation, obviously there's been some sort of changes to the BRCA genes, which then increase the likelihood of breast and ovarian cancers. We'd love to see the development of a familial cancer registry to track and intervene with families with hereditary cancer rather than reacting when people are diagnosed. We'd like to see, I think what we're talking about overall here is much more early intervention, proactive funding. So when we're thinking about that health budget as a bucket, for want of another way of describing it, we just want to see larger investment early, larger investment in a proactive sense, and we want to legislate against genetic discrimination by insurance companies, because we see women having testing as a public health issue. If women are taking that action and doing that, we don't want women to then be discriminated because they've checked out and know their status now. In Australia, I think it was early April that they passed unanimously a piece of legislation to make it illegal in Australia for insurance companies to discriminate. And we would certainly like to see, something like that happening here. Then the gynae-oncology specialists, we know that we simply don't have enough for the population that we have. So there's been some investment and some work done in terms of recruiting people to train, but we know, for example, that a lot of women are having to travel well out of district to access care, and that those that are working in this space are working really hard in terms of being able to manage and be responsive to the population. So we want to care for those that we have, and we know also that those gynae-oncologists work best with a great team around them. So it's not just investing in them, but it's also clinical nurse specialists, it's great administrators and coordinators, and it's those teams being supported to deliver the work. And we need to not only recruit people, but we need to retain them and we need to train them. So it's kind of, the three sides of the triangle, I suppose you might say: recruit, train and retain people. We want to see prioritisation of access to ovarian cancer clinical trials. It's hard to get on a trial here in New Zealand. Currently there are 5. There are 44 in Australia by way of contrast, which is why you'll see or hear from some women about plans to go to Australia in order to be able to access those trials. And we want to see increased funding and focus by the Health Research Council. There's been very little research funded on ovarian cancer. It's also part of why we have a really strong commitment to it. We know how essential it is to really transforming outcomes to have that research investment. So it's a big part of our fundraising every year, and every cent that we raise in those research-focused campaigns goes directly to those grants that I talked to you about. So it's incredibly important. We want to have women with lived experience obviously being part of all of this, just as we've talked about their involvement. We have lived experience advisory groups for women, we have lived experience advisory groups for family, and they're very much part of the work that we do and how we go about shaping up and framing that work through their input into design and early stage planning and those sorts of things, not just signing off things that have been developed by others. And the last area is really around medicines access and investment. This is a very significant issue for women. Currently in New Zealand, we allocate, if you imagine again, if I go back to my bucket idea, if we think about our current health spend, we probably, of that total health spend, we probably spend just under about 5% on medicines. Now, the OECD as a group has been around, I think it's about the same age as me, came out of the 60s, 38 countries, and the investment in other OECD countries sits at about 13.5%. So if you compare our 5% of that health bucket compared to what other comparable countries are spending, we're well shy of that, aren't we? Those, if you look at those two figures, we're well shy. So what does that mean? It means people are missing out. They're missing out on medicines that have been approved as safe, that are considered treatment, a standard treatment option in other countries, but not available here. So that impacts outcomes, it impacts life itself and the quality of that life as well. So medicines access is something we feel very strongly about, and we think that there is an opportunity for proactive investment in medicines early on rather than the spend that we have currently that happens latterly. When people are unwell and needing services, we'd like to see that support early on and much better investment. Currently, when things are approved, they're approved by MedSafe. They come through then to Pharmac. Pharmac are looking at whether they do manage the budget, but they're also looking at the list of all those that are coming through, the budget that they have, what they can fund. So what they do is maintain kind of a list, you might call it. So it's options for investment, it's called, and that lists all the medicines that would be of benefit if they were funded, and then the decisions have to be made. But some of those things can be on that list for a long time. One of the medicines that we were keen to have funded, I think it sat on the options list for 12 years or something like that. So the wait time's significant when you're facing, a really serious illness, and you're wanting access to a medicine, because otherwise your option is you're gonna crowdfund it. You might get a mortgage, you might borrow some money, your family might see what they're able to do in terms of pulling together what resources they've got. All of those things make it incredibly difficult for women when they're making a decision about the financial burden for their family versus their continued ability to live or live longer and live with some quality. So these are extremely difficult positions for women and their families to be in, and we would certainly like to see better access and a much stronger level of investment in medicine. So, in summary, what are we saying? Where we kind of got to was it could be better, and actually it should be. We want to see lived experience voices informing service design and evaluation generally. We don't think that's a nice to do or an optional thing to do. We think it actually should be an essential part of how everything is done. We want to see much more investment in research, earlier diagnosis for women, and at the moment that's through awareness because we don't have that screening tool. better access to clinical trials and treatments, access to that real-time data that we know we could get through a register, stronger wraparound support, and just really a further improvement to those survival rates. We want those to be better. We've seen with the level of investment and visibility that other cancers have what's possible. So that heartens us and gives us hope that it can be better for women living with ovarian cancer as well. So what are we doing? There's, our commitment and the support we need from all of you on the call today is really around committing to knowing the signs and symptoms. Like if you're listening to me and thinking, what are they actually? Then that would be a great thing to be looking up and having some understanding of. And you'll see when you're thinking about those and you're thinking about things like bloating and you're thinking about changes to bowel and bladder habits and feeling full when you haven't eaten much and abdominal pain and things, you can understand that initially that might be seen to be some other things like irritable bowel that we talked about before. But where those symptoms are continuing and they're of 2 to 4 weeks duration, we are encouraging women to go to their GPs or primary healthcare provider and be checked. And that if those continue, that they go back again. That if they continue to present and don't feel listened or responded to, we talk then about second opinion and the importance of actually trusting what you know is your norm. You know your body best, you've been in it, and you've got a sense of what's different, what's new for you, what feels different to you. So really supporting women to lean into that. And to have people with them if they need support in a consultation themselves, and to be not afraid to ask for a second opinion. You can post on social media about some of these things, of course. We're in an election year, so there's an opportunity for all of us, I think, to be really signalling the importance of some of this health messaging and to garner people's support and interest and share with people that you know. And then just to close, this was one of the quotes that Ruby wrote for me about being part of the Lived Experience Advisory Group and why it was important to her. So I just want to close with this, and then I'll pass back to Ragnar. But she wrote this. Living with ovarian cancer has given me a deep understanding of how isolating and overwhelming this journey can be. I've seen firsthand that while research is essential, so too is the need for practical, compassionate support that helps women feel seen and guided through every stage. Being part of this group, so she's referring here to the Lived Experience group, is about helping shape that change, bringing real experiences to the table so no woman feels unheard or left behind. So yeah, thank you so much for listening, and I'm hoping that in amongst there might be some things that resonate with you. It might be that you've had an experience yourself or an experience for someone close to you with ovarian cancer. I think over the field days, those 4 days, we had about 48 people share with us about someone that they knew who had ovarian cancer. So whilst those numbers might seem smaller compared to other numbers in terms of total of people diagnosed in a year, there's still significant numbers, and so we are able to help shift that dial where we grow our allies and the number of us kind of calling for change together. So thank you, and I'll pass to you now, Ragnar. Thanks so much.
Thank you so much, Liz. That was a really compelling presentation. I really want to acknowledge and just value the way in which you've highlighted women's voices and those who have had experiences with this, because I think often when we're in research or clinical spaces, it can be easy to kind of look at numbers and forget what this is like on a just for individuals and their, as you say, lived experience of going through cancer diagnosis and treatment, et cetera. So thank you. And also such a clear presentation around what is needed. I have a few questions, but before I ask, I want to open it up. If anyone would like to ask Liz a question, you feel free to raise your virtual hand or your actual hand, and I'll ask you to come forward with that question. Okay, well then maybe I will ask a few of mine. The first thing that comes to mind, I was so struck by the idea that people who have the HPV vaccine or who have a cervical swab are under the impression that this covers detection of ovarian cancer. I'm wondering if this is something, because there's so much advocacy being done and a lot of media coverage around cervical cancer, which is fantastic. I wonder if there's a way, though, and maybe you're doing this to kind of figure out how to communicate that message for those people who are doing those screenings and other educators or even in the vaccine materials, which I received recently from my son who's in year 7. So just wondering if that's been on the landscape of like thinking about how to convey that yes, this covers many cancers and gynecological cancers, but not all.
Yeah, yeah. I mean, look, what you're saying is exactly right. I think, I think that if we go back and we think about the cervical program, it was such an important one because we think back to National Women's Hospital, we think about the Cartwright Report, we think about the beginnings, if you like, the appointment of Robin Stent as our first commissioner back in the day, and the Code of Rights. I remember going to all those consultation meetings. There were a whole lot of things that came up and out of that that are so important, and it's been so successful. I think where we're seeing the way forward is there's an opportunity and a conversation to be had and a couple of sentences to be included in print materials that just make it clear about what it is not. That's it really.
Yeah.
We can as women cope with having conversation about a couple of different things at the same time. I had someone suggest to me that women would be confused by that. I said, I think we'll cope. And I think the important thing is to just be clear around what it is that you're doing and what you've had. Great that you did it, but also what it isn't testing for. And knowing so if you've got these other symptoms, you do need to still come and be seen. With HPV, I mean, same here with my granddaughter, sort of looking at the wording around that, and I thought, I don't think that that would be too hard either. So we've
Mm.
been playing with sort of a couple of sentences and what that might look like. We've already been doing lots of work, as I said to you, on awareness of signs and symptoms. We were in about 91 general practices. We had pamphlets
Mm.
out. We've done wallet cards out to all I mean, we've been doing so many different things. But I think the opportunity here is to just look at what we can do in that HPV space as well. Because I think if we want a level of literacy, we've got to not only talk about what things are, but what they're not. And the key that the bit that concerns me is that if we've got a younger, I think our messaging shouldn't be standard, if you like. It does need to be tailored for younger people, just as it does need to be targeted to older women like me, because we've also got older women thinking that this isn't relevant for them because they're postmenopausal. So therefore, none of this kind of is related to them. But the average age of diagnosis is 65, right? So this is very much an issue for our nans, and our aunties. And so I think our messaging, taking that lifespan approach to our messaging and thinking about how we can do that best. We also need to be thinking about our LGBTI community. We need to be thinking about our different ethnic and cultural communities and some of the nuances around what's appropriate to say and how
Mm.
and when. So there are a whole lot of things. When we talked, we have since the report spoken to Health Select Committee about these things as well. And we've been meeting with ministers. We're regularly just continuing to kind of press forward. But I just think there is an opportunity with what we're doing now in primary care to and in other services to be ensuring that the messaging is not only about what these provisions are, but what they're not.
Yeah, absolutely. And I really appreciate what you're saying around, raising the awareness among GPs so that they can, as you say, send for ultrasound, send for that particular CA125, like really have a very clear plan. There's a couple messages through the chat. I'm wondering, Elizabeth, would you like to just say your message instead of my reading it, or would you like me to read it?
Sure. Okay, can you talk? Hang on, I'll just put my little ear in my. I just put. Hi, Liz. I've
Hey.
known you since your VTA years, so nice to see you again. Look, I was really taken by the statistics around the numbers or the low numbers of people who actually understand what some of the symptoms are, and kind of understandable that it's getting dismissed perhaps for maybe perimenopause or the starts of change in life. Do you see that playing out? And is that particular, is that one of the reasons perhaps that GPs are dismissing symptoms?
I mean, I'm not sure that the answer is a simple one.
Mm,
I do think that I do think that, some women talk to me about not being able to enroll in a practice easily. Some women talk about the length of wait time to get an appointment. Some GPs have talked about referrals for ultrasound being triaged at the hospital end of things. So, I look at it and I see a whole lot of structural things kind of happening that are all contributing as well as the things that we've talked about specifically in the report. But I think that, yeah, there is an opportunity if we're targeted and clear about the outcome we're trying to achieve to shift the dial. I think we can do it, I really do.
mm,
Where we've got that shared understanding. And a lot of these things, when I look at them and you think about them as an action, they're not rocket science, it's not rocket science, some of this stuff. Yeah, yeah.
mm. Yeah, thanks, Liz. And
Yeah,
nice to see
thanks.
you
Thanks.
again.
Nice to see you too. You too.
To that end, I mean, I think Sue just put a comment in the chat, which maybe she'd like to just express on her own, but it's kind of along those lines. Sue, do you want to say your comment?
Kia ora, Liz. I wanted to say too, Jackie and I were at that event that you talked about, Parliament. I can't believe it was that long ago. And I would honestly say it's one of the most heartbreaking things. I don't recall sort of crying in public the way I did there. I just noted that there's a sort of a link, some linkages missing, aren't there, when you think about it? I am over 65, but when you turn that age, you start to get emails from the Office for Seniors, which I think is particularly rudely named, but they advise you on things like shingles vaccine. And it would seem that we're missing some of those
Mm,
opportunities that, as well as telling me about, winter heating payments or whatever, that the it wouldn't it wouldn't be beyond the realms of possibility for some simple messaging around these
yes,
kind of issues for people over 65, if that is an age thing. And I guess I've got some of my team on the call here today, and we manage websites and social media. And I think we'll go off this call and have a conversation around our HPV information
mm.
and how
Mm.
we can review that in light of what we've heard from you today. So not a question at all, but just
No, but that's
some
all
comments.
that's all great too, because I think what stands out for me there is that it is about thinking laterally as well. I mean, we can stay in that advocacy zone and say, well, look, it's about putting forward what's required to government. And yes, we've done that. And yes, we're continuing to work intentionally across each of those 8 actions. And that's great because it really does give us a very strong focused approach to what we're doing. But equally so, we need to take a lateral approach and think about, so where does that communication happen? What relationships do we have between ourselves where we could actually be advancing some of these issues with others? And who would be the allies around that particular ask? And if you think about the example like we've just talked about of HPV, 100% agree with you. There are things we, you and us, could be doing together in that space that would advance that. Similarly, I'm going to be talking to the College of Nurses and to the nurse practitioner group. And so that'll be Chelsea and Kate, and having a talk with them again around from a nursing perspective. So that's planned. We've only just kind of been chatting about it, but haven't yet done it because they've got their conference in Queenstown. But we'll come together to have a look at that and say, so what else could we through that community be doing? So I think we do have to think laterally. I love your idea. I hadn't considered that around talking to the Office for Seniors and thinking about what we might be able to develop up and provide there. Those are the conversations that matter, because these are all the ways we weave it in, and we find partners to help support us with that. So thank you for that suggestion. I'm definitely going to take that away. So thank you.
Thank you, Sue, and thank you, Liz. I have one quick question, unless anyone else would like to speak, because I would love to prioritize someone else's voice here. Anyone? Okay. I'm curious if there's been any research looking at a screening tool. If there's anything that you've heard of, I just feel like the fact that it feels like such a sort of blind abyss of not being able to find it until you have these symptoms, which are symptoms of so many other issues. So just wondering if you've heard of anything in development or.
Yeah, I have read some research about CA125, and
Mhm.
it had the potential to be a screening tool. Because, of course, naturally, when you know there's something that's got some markers in it, well, you're looking at something like that, because like there's a CA, I think it's CA153 for breast. I can't remember now what it was, but when I had breast cancer, you know, but some of the studies that have been done around that have indicated that it isn't necessarily a, a tool that is able to screen in isolation, because
Mm.
where some of that work was done, I think it was UK based. It was an article I read not long ago, journal article. It didn't necessarily show the kind of benefits that one would have thought might have come by perhaps adopting that. So I know there's been some discussion around that in terms of more broadly, what are they doing actively at the moment around screening? I'm not sure. I'm not
Okay.
sure is the honest answer. I have a few thoughts, but I wouldn't want to commit them to this discussion,
Okay.
because I'd want to talk to our researcher first and just check with her. But I have read that article about CA125, because that was immediately my thought. Wouldn't
Mm.
that be it? But no. And generally, if women are going and asking to have a CA125, there'd be an expectation, I think, in primary care that they'd be symptomatic in some way
Mm.
in order
Mhm.
to be able to have that. Yeah. And we would always, that's why they're saying with ultrasound rather than just, 125. Yeah.
Well, you're getting some thanks in the chat, so I want to make
Oh,
sure
thanks.
Brooke is saying thank you to you and for your work. And I think with this point we'll wrap it up. I do just want to acknowledge you've touched on so many different things, but particularly talking about these structural issues around Pharmac and the funding for medicine and these sort of really big picture access to GPs. I mean, these are things that we're talking about and thinking about all of the time in the health policy sector, and just appreciating, how those filter down and affect people's actual lives. And you've brought that up so clearly and really crystallized that for us. So I just want to say thank you, and thank you for taking the time to come and present. And this will be recorded. We will be sharing this. So if you all on the call today would be willing to share through your networks just to get the word out about this, because I think more people need to know about ovarian cancer and all of these complexities. So with that, I will pass it over to Sue Reed for our closing karakia.
Oh, kia ora. Thank you again, Liz. I'll just close this off from our kōrero today. So, ka whakaarea te tapu, kia waitea Aotearoa, kia tura ki whakataha ai, kia tura ki whakataha ai, home e hui e tai ki
Hi,
e.
Kiki. Thanks,
Thank you all
everyone.
so much. Ka kite.
Yeah, ka kite, everyone.
Thanks, Liz.